The Centers for Medicare and Medicaid Services have given the green light to states to block grant their Medicaid programs. In a letter dated January 30th, CMS, Centers for Medicare and Medicaid Services, sent state Medicaid directors a letter announcing an initiative they're calling the Healthy Adult Opportunity Initiative. What it really is a block grant opportunity that permits the states to use Section 1115 demonstration waivers to block grant their Medicaid program. Now, you might remember Section 1115 demonstration waivers as opportunities for the state to try an experiment, to try something new in their Medicaid program that deviates from federal Medicaid laws and rules and regulations because they think they can do Medicaid better. They can try a new initiative, they can see if it works, and see if it overall improves the health of the people of their state. So the feds have said to the states, you can use Section 1115 demonstration waivers to try an experiment called block grants, either in an aggregate or per capita cap financing arrangement, which essentially would mean that these states can sidestep a lot of the Medicaid requirements while also having a federal cap on the money coming into their state in the Medicaid program. So CMS says they want to do this. It'll give states flexibility in their state Medicaid program design and administration. They said it's an opportunity to test alternative approaches to the traditional Medicaid program that we have right now while keeping budget neutrality limits in mind. And that's really what they're talking about, caps in federal financing to states for Medicaid. So what it does, it allows states to implement huge program design changes like eliminating very popular features of Medicaid that are in place right now, like retroactive coverage, saying if you would have been eligible last month had you applied for coverage, your Medicaid can backdate and cover those hospital bills that you should have had been eligible for had you applied. It's a very popular feature of Medicaid that patients like and hospitals like because those bills get paid and reimbursed. But block granting could give states the flexibility to eliminate that feature. Similarly, you could eliminate presumptive eligibility. You could exclude certain prescription drugs from your drug formulary in your state. If you have very expensive drugs on your drug formulary, states could say, we don't want to pay for that anymore, and they could outright exclude them. You could impose new cost sharing. You could have premiums, for example, for your lowest income individuals enrolled in Medicaid. You could impose work requirements, which we've seen come through different waivers for other states tied up in litigation, but this could be another opportunity for states to ask for that from the federal government. And they would allow states to do all this to achieve political goals. And that's another bullet point that's important to know here, that this is not new. We've seen block grant proposals come through many administrations as far back as the Nixon administration. It's been tried. It hasn't been successful, and here's a couple reasons why, up until this point, of course. Because Medicaid is popular in every state and it covers a significant amount of our population. 71 million people nationwide are enrolled in one form of Medicaid or another. Medicaid is a federal-state partnership program where a state will contribute money to cover its Medicaid population, and the federal government will match that contribution using a formulary, usually based on the state's per capita income. That usually means that lower income states are getting a little bit more federal money than wealthier states. It is, and this is the existing Medicaid program we're still talking about, subject to federal standards. States design and administer their own programs, so they do have flexibility now to determine covered populations, services, delivery models, payment methods, and the federal government matches state Medicaid spending on an open-ended basis, and that's one of the biggest differences here. Currently, there is no limit to what the feds could contribute should the need arise, which is especially important in times of economic downturn, natural disasters. You could see even most recently in the news situations of coronavirus. Should there become a point where parts of our country need to respond more aggressively to a health hazard, or think of times of hurricane when a lot of people lose a lot of their current income, possessions, etc. Those may be times when including more people in Medicaid and having those costs go up could happen. Having a capped program under the Medicaid block grant model, which is being proposed here, would mean states would not see that increase in federal money. They would have to deal with it themselves. So while it sounds good for everyday use to some people, you could see how in times of economic downturn or a special need, it could be quite damaging. Now, block grants are seen as a cost containment method first and foremost. Scale back the federal contributions to states, keep it to a lump sum for the state to run their Medicaid program, and allow the states, meanwhile, to sidestep a lot of the Medicaid rules, which they argue, especially in eligibility and coverage, is what drives up the cost. Now, health policy experts looking at the new block grant initiative coming out of the Fed say that this leaves state taxpayers on the hook, especially as you can imagine in that hurricane example, and residents at risk of losing care. Shortcomings, and a lot have been identified. There are a lot of opponents to the block grant proposal. They are most concerned about limiting care for people that need it. We want to encourage people to have the health coverage they need so they can go to preventative health visits, regular primary care visits, not use the emergency room as their sole course of care only when things get dire enough to do so. Block grants do not automatically take population growth into account. We disconnect the level of funding from the number of Medicaid beneficiaries, the cost of care, not only disasters, but also the flip side of that, innovation. Overall, you can see how hospitals and providers might be concerned about a block grant method because they would see reduced reimbursements for the services they're providing. Now, other health policy experts and legal experts have pointed to some concerns about if the block grant initiative can even get off the ground. Congress, they argue, not the executive branch, is the one that has the authority to implement block grants. So can CMS even issue this initiative on their own without Congress? And even if it came out of Congress, proposals like this, like we've said, this theory has been around since the Nixon administration. Proposals put in front of the U.S. Congress have not been successful thus far. Now, we also have to just look at the definition of a Section 1115 demonstration waiver to see how a lawsuit or a challenge could happen just over whether a state has the authority to make these changes using this platform, using these demonstration waivers. Waivers are by definition used to enhance access to Medicaid and improve the health of the people of the state. And many would argue restricting access and cutting costs and cutting a lot of the Medicaid rules like backdating presumptive eligibility, prescription drug coverage, could be seen as the opposite. It would not be an appropriate use of a waiver. And again, is this an experiment? Block grant methods have been tried and failed in the past. So is it an experiment if we know it just might not work already? So that's some of the legal arguments that are being dusted off and ready potentially to be put forward should this end up in the courts. As you can imagine, it might. Now, states are not required to submit a waiver, but a lot of the politically charged states have already indicated a likelihood that they might take advantage of this opportunity. States, a lot of people argue, already have flexibility in their Medicaid program, so it really will be up to the leadership of each state to determine how they want to move forward. You can read a copy of CMS's letter to state Medicaid directors. We link to that in the description below. We also share the link to CMS's fact sheet. They bullet point out some of their talking points and thinking behind this block grant initiative, as they're calling again that Healthy Adult Opportunity Initiative, to see how it could look should a state move forward with these plans.